Well, we've been alluding a lot here to MRD, and let's get into the weeds of MRD testing and talk about that more. And I mentioned at the beginning, we called this initially minimal residual disease. People are moving to call this measurable residual disease, and I do like that term because it reminds me that all the tests we do have levels of detection, and people that are MRD negative can relapse, so we know that they still have residual disease there. It's just that it's below our limits of detection. But I think as you've heard from what we've been talking about so far, it's really emerged as, I don't think the only, but certainly one of the most important prognostic factors that we rely on in our management of these patients. I think we still need to take into account, obviously, the individual patient. I think we need to take into account their genetic features. We talked about the pH-like, some of the complex cytogenetic abnormalities that we can have. But I think we're finding that that measurable residual disease is replacing some of our traditional risk factors that we've relied on in the past. You alluded to some of those, Ryan, white count, age, things like that, and those I still take into account to some extent, but measurable residual disease has really emerged as the most important factor, and the pediatricians as so often we've seen, have led the way in ALL. Brian, we all know we don't practice in isolation. Tell us a little bit about your interactions with your hematopathologist and the other members of your care team.
Yeah, and I'll start by saying it. The first few years that I worked at the University of Washington, I forgot that our in-house flow cytometry was the COG reference lab quality. So I would talk to people about MRD testing with this sort of naive notion of like, oh, this is how it is for everybody. But of course, that's not how it is for everybody. So I think I'm really, really lucky to be able to work with outstanding hematopathologists that do this at a super high level. But for those of us not so fortunate to be able to tap into that world-class resource, I think it's really important, as Jay alluded to before, it really starts with the person doing the procedure, making sure that it's that first pull of the marrow aspirate, 2 to 3 milliliters or so. You don't want that first pull to be 10 mils and just hemodiluted. So whether that's the APP that you work with or that's in your procedure suite, if it's a radiologist, if it's a pathologist, whomever's doing it, I think that's really important. Knowing where that specimen is going to go. Again, for us, it goes to our lab, which is outstanding. But if you are in the community, your lab may contract with some outside facility that provides excellent reference lab quality flow cytometry. It may even come to the University of Washington. But if it's being run kind of in an in-house assay, it's worth talking to the pathologists about, well, what's the sensitivity of the assay you're using? What color or how many colors are you using with your flow cytometry? Because as I alluded to before, if the level of sensitivity is 0.1% or worse, it's going to be very hard to be able to utilize the data that are out there for MRD-directed therapy in a situation like this, because you're going to be falsely reassured. If you're in a situation where you don't have access to good quality flow cytometry as diagnostic testing, that might be a situation where looking into the commercially available high throughput sequencing assay that's available that can be sent if your lab is able to coordinate that. Again, we don't know exactly how to use that particular assay necessarily at these particular time points to make treatment decisions, but I would argue using an MRD assay that's maybe ahead of the curve, too sensitive, is probably better than using one that's not sensitive enough. So I think those are, there's lots of different touch points to potentially make sure that you're optimizing the way that these specimens get collected and handled and processed so that the data you get back is reliable.